Bernstein Show. Now, here's Ed.
Hey, if you have a heart, you want to watch this show. Today, we are joined by two highly respected medical professionals who bring valuable insight and expertise. First, I'm pleased to welcome Dr. Erik Sirulnick, and a little bit later in the show, we'll be joined by Dr. Rahul Handa, who will continue the discussion with more important information for our viewers. Dr. Sirulnick,
thank you.
Good to see you.
Thank you.
Now, you are, look, when people talk about cardiologists, there's a number of different specialties within cardiology, right?
Right, correct.
And your specialty deals with heart rhythm.
Correct.
Right?
Correct. I'm an arrhythmia specialist. I'm a cardiologist in training and board certified, but also in cardiac electrophysiology, which is the specialty of cardiac arrhythmias.
Right. So when I watch all these commercials about AFib on TV, that's the area that you're working on, right?
Correct.
What made you become a cardiologist?
I would say many reasons. When I was in med school, the great thing about cardiology is that you're really able to impact people immediately. So I can be in the office and help people manage their risk factors and their cholesterol and their blood pressure, but I can also be able to be in an emergency room and impact someone's situation right there. So cardiology is just very satisfying as a physician. I think that's what drew me to it.
I hear people describe the heart as, having a plumbing component, an electrical component, right? I mean, and there's different functionings of the heart and require different expertise, right?
Absolutely.
Yeah.
I mean, so people think of the heart as being a muscle, but within that muscle is that there's a nervous network in there. That nerve network makes that EKG. That's what you see on TV when you see those tracings of people hooked up to a heart monitor. That's what's making your heart beat. And so that nervous system that's embedded in the muscle of the heart is a very important component of heart health.
Right, and so the electrical impulses control the rhythm, basically. And is there for everybody, is there a normal rhythm that everybody has, or is it individualized?
It is. Everybody has, we're all essentially with a normal rhythm, and that's what makes that EKG that we all have, or when you do a tracing on your watch or you take your pulse. But there are some abnormalities that can happen to people during the course of life, one of which is atrial fibrillation. That's a very common arrhythmia that affects many people as we get older.
What exactly is it?
So atrial fibrillation is the normal network that allows for your heartbeat to conduct at appropriate rates. It falls off that nerve network. The network of nerve in the heart is like a little, very primitive little nerve. It's like a little spider's web of a nerve that's embedded in the muscle. And there's a little impulse that's going down that thing. But unfortunately, we're all with a very primitive little system. It's easy for it to get muffled. And so what can happen is that the nerve will fall off that little network. And when you're out of rhythm, you go into a second backup rhythm that is often atrial fibrillation. That atrial fibrillation is more erratic, it's less efficient, and so people can have symptoms. You can have significant shortness of breath. There is an absolute risk of stroke associated with atrial fibrillation, and so many people who are on a blood thinner to protect them from that. But thankfully, there are a lot of treatments and strategies to reduce or eliminate AFib.
Is it always like a higher or more rapid heartbeat, or can it also be lower?
It can be faster, it can be slower. It's just more erratic. I tell people it's a lot like being on a bicycle and you're just stuck in a lower gear on the bike. And so the bike is working, but it's just less efficient because you're trying to catch up. And what you want to try to do is snap back into the normal rhythm. It's like snapping back into the normal gear on a bike.
And can you be born with this? Is it genetic, or is it?
Most people are not congenital heart disease. Children with heart conditions can have AFib at a young age, but for the most of us, it becomes something we develop as we get older. The number one cause is probably just hypertension, high blood pressure. High blood pressure does do some subtle changes to the heart over time, and then the nerve network just gets a little muffled from those changes, and then you're able to go into AFib from high blood pressure.
And it sounds, by watching television, I assume it is very common.
Very common.
Yeah.
So there are probably 10, 20 million Americans with AFib. a lot of Americans who have it don't even know they have it. So half the folks who have it won't know it, and that's why there really is a stroke risk associated with it.
But when you say they don't know it, I mean, there are symptoms that they're ignoring, basically. I mean, you walk up a flight of high steps and you're winded at the end, your heartbeat starts racing, and that would be a sign, right?
Remarkably, half the folks who have it really have no idea. So you can have people who go into it once or twice a year, and when they're in it, they're feeling awful. They know. They say, "Doc, I got to take care of this thing." You can have others who are discover that they're in it just by their physician, and they have absolutely no idea, and it could have been going on for years beforehand. So there's a mosaic of how it presents.
Now, once you get diagnosed with atrial fibrillation, then is your first step to medicine, or is it surgery? Is it a procedure? What do you?
So
how does that work?
the most important issue with AFib is it's a major cause of stroke. So the patient really wants to, the doctor really wants to make sure that we can address a blood thinner and immediately controlling that stroke risk. Once the stroke risk is addressed, then it really can be managed somewhat, at the leisure of the patient, depending on how symptomatic they are.
So I mean, so typically you prescribe medication.
Yeah.
And essentially the medication allows the heart rate to not exceed a certain level or not go lower than a certain level, kind of puts it within a range.
Yeah, so the first drug is the blood thinner. So if someone is in AFib, the medication is just, it's like an aspirin. There are choices. People have heard of Eliquis or warfarin or Xarelto or other medications. It will just be a blood thinner. It doesn't control the heart rate at all. It just thins the blood and protects them from stroke. Then there are medications to make the AFib rates more controlled and tolerated. Medications that will control the rates, and then there are other medications that we call antiarrhythmics that will suppress the AFib. And then there's also procedures like ablation and things like that.
And let's talk about that, because I have some firsthand experience in this, because I was diagnosed with AFib and for years was taking some, not the blood thinners, but etrofol. And then I spoke to Dr. Sirulnick about something called an ablation. Didn't have any idea what it was. It essentially went in for an outpatient procedure, right?
Yes.
All I know is I went to sleep and I woke up later that day with no problems. Couldn't believe how quickly the remedy was for this. But what did you do while I was sleeping?
So just to specify, your condition was not AFib.
Right.
It was more of a benign kind of issue where, and many people do get other arrhythmias where the heart will just go fast for other reasons that are not putting someone at risk for stroke. But the ablation is a procedure for that too.
I had tachycardia.
For a tachycardia.
Yeah.
So what we're doing is we're going into the heart. This is a procedure that is done now through a bunch of IVs. 25 years ago, if someone had an arrhythmia procedure, it was open heart. So the surgeon would have to open the chest and patients would recover for 6 weeks. And now we've evolved over 25 years to a procedure that is done through a few IVs with anesthesia, but it's much less invasive. But it really gives us the doctor the ability to work on people who would have otherwise been so high risk to take them for surgeries. Now this can be done in healthy people, but it can also be done in people who are just very debilitated and all through in between. The ablation procedure is about a 1 or 2 hour procedure where the doctor is putting a catheter, which is like a little plastic tube, into the heart through the veins and arteries. There are no pain receptors on the inside of these vessels, but you're sedated to be kept comfortable. And then we're able to map that structure and, if safe, then ablate it or cauterize it to get rid of it.
And the difference between AFib and the tachycardia that I had, what is that?
AFib is a problem with the whole network. So the nerve is kind of, like I was saying in the beginning, like a web that's embedded in the back structure of the heart. With the tachycardia that you had, it was really just one little focus. It's one little heart cell that's like twitching, like a little eye twitch. And it's just acting out of line, like a little kid in the back of the class that's speaking when he shouldn't, or she shouldn't. So we're able to just kind of go out there and just pluck that little kid out of the class.
And
that's what you have.
How do you recognize where that area is?
So when we do the ablation, we're going in with very conventional strategies to try to kind of bracket or hone in on that thing. I put these little catheters in there that let me see very conventional positions in there, a little bit like flying over a football field and seeing where's the zero, where's the yard line, where's the the 0 yard line, the 50-yard line, and then being able to track and hone it down that way. So it really, these arrhythmias can come from anywhere in the heart, any of the 4 chambers, anywhere in the middle, within the system. And then what we're doing is we're honing in on it, bracketing it down, and then once I know where it's at, then going in with a catheter, an energy, heat, cold, or there's another one called PFA, that allows me to then cauterize and eliminate that little nerve.
And the recovery was almost instantaneous.
Yeah.
In my experience.
And that's the nice thing, is because we've been doing this for 25 years, and so many millions of people have cardiac arrhythmias, there's so much investment and research into this area and advancing the technology to make it less and less invasive, and also to make the recovery much quicker. Yeah.
Is everybody a candidate for an ablation if you have AFib or tachycardia, or are there only certain candidates?
Most are candidates.
Yeah.
So we go by guidelines. We have guidelines by the American College of Cardiology, American Heart Association, and European guidelines and such that really guide us to do the right thing for everybody and put them through a pathway. And often with arrhythmias, a pathway is going to start with a medication, but after the medication, if it's not effective, then go to a procedure that can eliminate this thing.
Is there a way to avoid arrhythmia to begin with by taking care of your heart? Is there anything I could have done?
Your situation, perhaps not. You have a healthy heart. Obviously, you've had your some of the things you went through, but you really do have a healthy heart. And this thing just kind of popped up like a little twitch of a nerve bundle. AFib is probably preventable in many ways. And I know we can probably spend a whole hour just talking about prevention, but just trying to keep a healthy lifestyle when you're younger or when you are healthier, you can prevent AFib in future time.
And when you say keep a healthy lifestyle, I mean, it's exercise, food, diet, weight.
Yes.
Those are the type of things you're talking about?
Yes. And when we think about the average American who struggles with things like high blood pressure, diabetes, with weight and cholesterol, these are challenges for so many millions of Americans, like tens of millions of Americans. And so it really does start with addressing important risk factors to control blood pressure, control cholesterol, minimize diabetes, and eat well and exercise.
At what age would you recommend somebody start looking into blood tests, cholesterol tests, ultrasounds, whatever other tests that a cardiologist would initially perform?
It really does start probably with one screening test in a young person under 18 to just make sure they're not carrying some genetic high cholesterol or high blood pressure condition.
Is that a blood test or?
A blood test for the cholesterol, an exam by a physician to check blood pressure. Those are probably the most important things to do when they're young. And then as they get into young and mid-adulthood, to have routine blood testing to screen, have blood pressure checked, and an exam.
And when you're a young person, you're getting these exams for the first time, the doctor puts on the stethoscope, he listens to your heartbeat. Are you able to tell at that point, or are you able to hear whether or not there is an arrhythmia?
Absolutely.
Yeah.
So just by checking someone's pulse, I can tell if someone's having an arrhythmia. And there are young, healthy people that have arrhythmias that are not life-threatening, that still happen to them. And those things can be picked up on a pulse. And then, of course, then if there's something that's not right on that pulse, then we can do an EKG right in the office and see if there's something wrong with that. And then checking just simple vitals and exam.
And what's your feeling about like Apple Watches and EKGs that you can do at home?
These are fantastic.
Yeah.
I mean, we all think this is we agree. The medical community sees the incredible benefit of this stuff, and the watches to be able to follow our biorhythms and help people to be a little bit more aware of their bodies. It's not only helpful to be diagnostic, but it motivates people to be healthier. And of course, I know we can talk all day about AI and how that's being used in these modalities to help compare someone's tracings to a database of millions of people and pick up on things early. So this is really exciting stuff.
And I know in my situation, for a period of time, you had me wear a monitor. What
Yep.
did that discern for you?
So if someone has something that we're sensing that may be wrong, or perhaps palpitations and we're still trying to diagnose, I mean, these watches are great, these consumer devices are good, but they are just consumer devices and they're not perfect. And so it still can be helpful to put on a heart monitor, because every tracing then is picked up for a period of time and the doctor can take a look.
Right. So
and pick things up.
24/7 photograph or video of what's going on in your heart.
Yes, and pick up the not just the moment of having it, but from the doctor's perspective, the onset, how long it lasted, the way it stopped, the offset, and the frequency of it.
Right. Well, hey, thank you so much, Dr. Sirulnick. If you have any questions, you can contact Dr. Sirulnick, and we'll be right back with Dr. Handa.
Thank you.
They hit us. Spun the vehicle around. I hit my head on the window. It was unbelievable. I called somebody I felt like I could trust. I grew up watching Ed Bernstein. They never treated me like I was just a number, and I am so thankful that I made that call.
Hey, we're back talking about the most important thing you have, your heart. With me is Dr. Rahul Handa.
Yep.
And you are a cardiovascular and thoracic surgeon.
Yep.
What is that difference compared to just a normal heart surgeon?
Yeah. Well, so it's a kind of it is a heart surgeon basically.
Okay.
Thoracic is basically operating on the lungs, the esophagus, etc.
Right.
So it's everything in the chest basically. It's a chest surgeon. But my practice primarily is hearts, and so. You know, that's when people think open heart surgery, that's the kind of surgeon they're talking about, cardiothoracic surgery, basically. But compared to a cardiologist, we're the folks who actually do open heart surgery. So we're going to the operating room, making an incision, and going from there.
Right, and so you're doing minimally invasive procedures?
Maybe quite the opposite, actually.
Okay.
Now, there is a minimally invasive arm to heart surgery,
Okay.
but most of our procedures are through a full kind of sternotomy incision. And we use the heart and lung machine, so we stop the heart, and then we kind of perform what we need to do.
Well, and when you stop the heart during these procedures, I mean, it sounds so, fragile.
Yeah.
But it's somewhat commonplace today, right?
It is, and so it's all about kind of the history of heart surgery is this amazing thing where back in the early, I should say like the 1900s, for the first 50 years or so of that century, we were saying anyone who operates on the heart should lose the respect of all of their colleagues. But now, for the last almost 75 years or so, we've had the heart and lung machine, which allows us to stop the heart safely, create a motionless and bloodless field to be able to operate on the heart. It is very delicate still, but yes, it's commonplace. It's what we're trained to do.
And you have developed a very unique niche within your profession, where you're combining AI and you're combining the internet, as well as broadening, I guess via Zoom, services and opinions around the world, right? Can you explain, what exactly you're doing with AI and how it's been helpful for you?
Yeah, sure. So we're building a company right now, basically, that is trying to help patients and providers at the point of decision making. So is this somebody that really should be operated on? Are they in the right hands? So the right surgery for the right patient at the right time and in the right hands. That's what I always say. Today in the world, there is a profound asymmetry of information between the patient and the provider, and it's nobody's fault. It's just kind of the way the system is, right? So if I imagine you were in a clinic and you were told you need to open heart surgery, that's a very scary moment for you and for your family. And maybe the surgeon says you need this next week, and he's got to go. So the nurse practitioner comes in and says, you're about average risk, which is for heart surgery around, more or less 1 in 30. And you have to kind of sign this consent form now, and you don't know anything about the surgeon or the institution, the operation itself, what your problem is, what alternatives are out there, et cetera. And so that's kind of what we're trying to attack, is that moment right there. So what we did was we built from the ground up a 28 agent pipeline that is able to go out and perform what would ordinarily be several hours of work for multiple people, and it never gets done in the clinical setting because it's almost impossible. But to help at that decision-making standpoint. And the thought is that we can use that information to help world-class cardiovascular experts, help the patients and insurance companies and hospitals make the right decision about who to operate on and change the outcome, so that 1 in 30 becomes 1 in 100 or 1 in 1,000.
So how would I know to even, explore these opportunities of having somebody take a look at my situation and kind of match me up with the right care provider?
Yeah, that's a great question. And so folks will come to us in a couple different ways. Sometimes it's through the insurance company or from the hospital, but most people, it's them, or it's oftentimes a family member that's looking online because they're scared, right? They were just told they need heart surgery, and they're on the computer in the middle of the night looking up what are the risks of this procedure. So most people will find us online through that avenue, and you'd be maybe it's surprising, maybe it's not, but about 15 to 20% of people who are told they need heart surgery, even if they are all in on that doctor or hospital, are looking online already for just to have somebody kind of weigh in on it.
And is there times when people are told they do need heart surgery and they really don't?
Absolutely, and that kind of comes to a deeper question about, are we really a second opinion service, right? And I don't like that terminology. Second to me implies that there was a first and it was wrong. Opinion means that it's not data backed. So I think really what we're doing is helping kind of the decision aspect of that, and we're really more of a cardiac teammate or a co-pilot, if you will. There are times when, we will absolutely say, hey, maybe we should order this study beforehand, or maybe tack on this thing to that procedure, or whatever the case may be. But over 90% of the time, it's not that the current surgeon or something is wrong. It's more so that the family and the patient want someone that they can talk to from the time that they were told they need heart surgery to validate the plan, and then thereafter. So that's kind of what we help with.
I mean, for a number of years, I mean, you were a surgeon, basically. I mean, you worked on Troy, who's been working on our show forever, and Troy is cameraman on the show, who owes you his life, he keeps telling me.
Oh gosh.
but you decided to go into a different direction.
Right.
What went into that decision?
Yeah, I think really for me it was that gap that I was telling you about. It's that moment, right, when a patient is forced to make a decision without the full picture, the full information. Again, it's not the surgeon's fault or the cardiologist's fault. It's just the way the system is. And I figured, I could do a couple thousand procedures over the course of the next 20 years or whatever the case may be, or I could help patients all over the world in a really efficient way if we could just take this kind of paradigm that we've created and use AI to do that efficiently.
And how is it different, what you're doing, like me going onto Claude or Chat GPT?
Yeah, that's a great question. So in several ways. The first is that the sequence in which those particular agents fire is proprietary. The second is that each one of those agents was built from the ground up with a brain of its own that we have basically created and constrained using decades of clinical and operative experience. So if you were to go onto Claude or ChatGPT, they'll actually give you quite an accurate answer most of the time, but there is some ambiguity there, right? And you might not even know the question to ask the interface, and you're never going to be talking to a human being. So what we do is every case gets both a cardiologist and a cardiac surgeon, which in and of itself, that's a class 1 recommendation from all major cardiovascular societies. And those two providers are available to the patient from the time that they kind of join our service through 30 days after their procedure. So the ability for a family member on, while the patient's in the operating room or thereafter, where they can't talk, they have a breathing tube in or whatever it is, chest tubes, pacing wires, the family to call us and get a call right back and talk to them about what's going on is, I think, really it makes them feel more safe through the process.
Yeah. I recall, years ago, my dad had an open heart surgery. He was where did he go? He went to UCLA.
Mm-hmm.
Weren't really doing it in Las Vegas at the time.
Yeah.
But I know how difficult his procedure and recovery was, and I assume that it's a little bit easier in today's world.
Well, yeah, I don't know. It's still open heart surgery is one of those things that it can never really be the easiest recovery. But I trained at UCLA, so I know those guys pretty well, and I'm pretty sure I know whichever surgeon operated on him. They're the best of the best. It's one of the places that we actually are actively chatting to and helping patients get to when they have a case in the community.
Because you then match up the patient with, maybe there's not a hospital, in
Exactly.
your local area that can provide the kind of service and expertise you need.
That's exactly right. And our team has those connections. We can do it very, very, very quickly. I'll give you an example. There was a guy out on the East Coast who was booked for surgery, and immediately, and he had actually never spoken to anyone but the nurse practitioner. He got in touch with us. He had 7 kids. We ordered a CT scan. He had a big abdominal tumor, and if he had gone to surgery, he probably would have died because of the heart and lung machine. So our team got in touch with the chairman at Johns Hopkins, sent him over there, got him there in 48 hours. They took care of him, and he's doing great. He's bench pressing 200 pounds now. So.
Wow.
Those are the kinds of things that we can do for folks.
Well, shedding light on this type of thing is a blessing. Thank you that you're creating a company that can do this. Now, how can people get in touch with you?
Well, I appreciate your kind words. So the easiest way is to go to www.whiteglovemd.com.
White Glove is the name of your company?
White Glove MD.
Yeah. Okay.
And today we're doing only cardiovascular care, but the goal is to actually expand this over time to every specialty. So they can go there, and right now we even have inaugural discounts. It's actually quite simple once you get there to get in touch with us.
Well, it's an amazing opportunity to be able to get this kind of information before you make a mistake. But thank you so much, Dr. Handa.
Oh, it's a pleasure. Thanks for having me on.
Dr. Handa.